So here we are 5 years later, and the book's done pretty good. But it's time to sort of think about what came out of the book well, what didn't come out of the book well, and then maybe rephrase the conversation about what are the issues that are out there that confront the midlife cyclist. Does that sound okay? Does that sound good?
Yes, the book was future scoping quite a lot, I think. I did mean it when I said it was something that needed to be written. The people aged between 40 and 70 now are the first generation who've tried to do proper sport beyond the age that most elite or professional sports people cease doing sport.
Yeah.
And so the science, the medical practice, and the whole narrative around it is something that's being written by people who are interested in it.
Yeah. And of course, this seems to affect men more than women. And with men, we have this dissonance of that somehow we're immortal, and just because we're getting old, we can keep doing what we were doing and we'll be fine.
Yes.
And I guess the book was one of the things the book was trying to achieve is, well, will you be fine? And in fact, the chapter you helped me with was called Will I Die?
Yes.
Suitably irreverent and blunt proposition.
Well, the answer was obviously yes.
Yes, you will. That's right. I mean, surfers are always worried about the sharks in the water. Midlife cyclists, especially men, our sharks circling us is heart disease. I mean, it's the big one.
Yes.
You deal with it every single day, so it's not an emotional subject for you, but it is for everybody else. It's the shark, that we're dreading, that we're cycling along and, oh my God, we got chest pain or something happens. So I want to sort of maybe start with that and think about what the top three things you see midlife athletes coming into you in clinic with, what they might present with.
So to preface that, I think it's worthwhile saying something about exercise versus health. With the exception of orthopedic problems, which can come from falling off your bike or skiing accidents, most health, and certainly most chronic health issues, are uncontroversially helped and prevented by being physically active. Dementia, common cancers, it's obviously true. Epidemiological evidence shows us it. But exercise versus the heart is a little bit more complicated because there are some abnormalities and maybe some conditions in the heart which are aggravated by exercise, maybe caused by being physically active. There are lots of things in the heart which are beneficially affected by being physically active and exercising. And there are also people who have treated heart disease who want to still enjoy what they used to do. And it's quite a complicated question sometimes as to what they could reasonably do and what risk is acceptable for them to take.
And in the book, one of the things that I talk about, and you help me talk about, is this apparent paradox that the more you cycle and the harder you train and the longer you train, there seems to be this greater incidence of kind of clots, if you like, or atherosclerosis in the coronary arteries. And this seemed to be a paradox that was seized upon by the populist press, that middle-aged men were killing themselves by training. And that was one of the things that I was trying to sort of meet head on. Yes. Has that advice changed now, or?
Well, I think the understanding has become much clearer. So just to take a little bit of a step back from it, if you sit in a cardiology clinic and evaluate people who come to you with chest pain, not sports people, just anyone, often the way that you would start would be by doing a CT scan of their heart. CT is now a simple test, low radiation dose, very little downside. And the more calcium is seen in the arteries of the heart, the more likely it is that they've got worrisome coronary artery disease. So that remains true. And an extraordinary piece of observational research confounded that simple thing when some sibling pairs were examined by colleagues in New York. And one pair of the siblings had to have run a certain number of marathons and the other one had to be sedentary. And the expectation is that the sedentary ones would have a lot of coronary calcium on average, and the runners, who are less likely to die from their heart, would not. And quite the reverse was found. The runners had lots of calcium. And then we compare that up with another similar piece of observation, which is if you take statins, you will get increasing amounts of coronary calcification in parallel with reducing your risk of a heart attack. And so just talking about coronary calcium belies the complexity of what we're actually dealing with. The calcium's a marker. It's not the thing itself. The fatty plaques that make up coronary heart disease, the cells within them express bone proteins for reasons quite understood, and therefore they lay down calcium. So some people with some types of plaques do have calcium in them. But the plaques that are dangerous for us, the ones that can abruptly change, as we would say, rupture and trigger a blood clot to obstruct the artery and cause a heart attack, they're physically fragile and unstable. They contain a lot of fat. The other type of plaque is made of fibrous and calcified tissue and is inert. And as long as the artery still functions satisfactorily as a tube, it's a harmless thing.
Yep.
And so the concepts emerged that increasing coronary calcification in people who have healthy behaviors, they're doing regular exercise, they're taking statins if they've got a high cholesterol, may get increasing coronary calcification, but they're not getting increasing coronary risk, quite the reverse.
So it's almost like cycling and endurance exercise is nature's statin.
Yes, that's right. And I would see regularly people who've paid a sum of money to walk in and have a CT scan of their chest, and then they come back and they've got a high calcium score. They're very concerned, but it ain't quite as simple as that. And then we need to evaluate them and hopefully reassure them that the calcium may be there, but it's not about to cause them harm.
I remember when you and I were talking, you had this lovely expression of, it's always stayed with me, I maybe used it in the book, it was like exercise naivety. So you can split the midlife cohort, people who are just coming to exercise, so
Yes.
their bodies are what you called exercise naive, and then you've got the people, the old dogs like you and I have been knocking around for years and years and years who've never really stopped.
Yes.
And the risk profile is actually a little bit different.
The risk profile in one is known and in the other is unknown. I think that's
Nicer put, yeah, well put.
more
Yep.
the way it is. So if a person has enjoyed sport from teenage years up to the age of 60, they're in contact with their body, they know how they should feel, and also they've done something which is a powerfully protective behavior. And if somebody like that comes to see me and they're embarking on a big challenge, they're rowing across the Atlantic or something, if they've got that history under their belt, I'm not doing a great deal, maybe some blood tests, a couple of simple things, and it almost always would reassure. Whereas a person might have enjoyed sport as a teenager at university and for the next 20 or 30 years has built a career, had a family, neglected the way that they should look after themselves. And with them, it's an unknown.
Yeah.
And they warrant much more of an evaluation if they're suddenly going to stress their system in a massive way.
Yeah. And often what I find from the bike fitter studio, my day job, is that those are the ones that are in a hurry. Yeah.
Aren't they?
Yeah. Because, they've lost that 25, 30 years, and their exercise age is different to their calendar age, and they're in a hurry, and they want to do the Etap and the Marmot and the Haute Route, and so they are going to suddenly stress their body in a way that they're not used to.
And you see it quite a lot with other types of challenge events. People want to run a marathon from a standing start, literally, in 4 months.
Yeah.
And quite often they will then be turning up to the podiatrist, the physiotherapist and so on because they've got tendinitis and this and that, because they don't have 20 years of cross-country
That's right.
in their legs.
Yeah.
It's the same thing. You're right. They're in a hurry. And I think there's also something about psychological challenge. You know, people want to do the Étape du Tour. They want to climb more than 2,000 meters in something that professional bike riders think is a hell of a challenge, and certainly to do it quickly and to do it with style.
Yeah.
So it's a huge ask.
Yeah, that's right. Yeah. And yeah, so and like you, the ones that concern me more are the ones that are new to this, in a hurry, and they want to out the blocks, and they, you know,
Yes.
It's all about intensity. And one of the things our colleague, Dr. John Baker, pulled out in the book, or I pulled out through him, was the fact that these ones train harder, this cohort train harder as a percentage of their maximum heart rate than professional athletes. So, they're spending too long at this kind of red line. And of course, we're crash test dummies. No one knows what this does to a body that's 50, 60 years old.
Yes, and I'm not a coach, but enough coaches whose opinion I respect say the same thing. If you take a professional cyclist, it probably takes 30 hours a week to reach their genetic potential, of which 25 are spent chatting, riding in a group, and 5 are spent going hard.
Yeah.
Whereas time-crunched amateur folk will do a majority of the 10 hours they can spare going quite hard and quite uncomfortably.
Yeah.
So they're adopting a physiological stress which doesn't seem to work for people who are good at the sport.
Yeah. So if we bring it back to this, you know, we're talking about coronary heart disease. So someone has an event, there's a blockage or partial blockage in the coronary arteries, and then, you know, they have whatever they have, chest pain, or they don't feel well, and they come to you, and they might have had some kind of intervention, whether that's some kind of, I mean, you can go through the interventions. I guess, what's their prognosis now after their post-issue with their coronary heart disease?
It's a broad group of people with quite a range of future risk.
Yeah.
And so maybe we'd start with people who've had what we in the trade would call an acute event, like a heart attack, and compare them with people who have chronic, reliable and reproducible symptoms because their heart muscle is short of blood and oxygen. So if we take the first group, the care of people having an acute heart attack has changed radically in the last 25 years. They do much better. They're much less likely to get a severely damaged heart muscle and much more likely to return to normal life. And cardiac rehabilitation has been a transformative process for these folk, both in terms of helping them regain their confidence and teaching them about structured exercise, whether or not they've enjoyed it before. So when I'm evaluating somebody who's had a heart attack, who's had successful care, I would ask myself 2 questions. How much has their heart been damaged? Because that informs the expectation of what they can do. And second, how much residual disease in the heart arteries is there? How much of is there still hidden risk in the arteries? And you might get one person who's had one blockage successfully treated and the other arteries look clean and the heart muscle is working normally or near normally. And as long as you plot a graded return to physical activity, you can set the bar pretty high for these folk. You know, there ain't much you would caution them about doing with an appropriate return to activity. And at the other end of that spectrum, you might have somebody who's had sustained a heart attack, who's got extensive heart damage, who's got a great deal of residual disease in their heart arteries. And although exercise is going to be beneficial for this person, it would be in a very different format with a different ceiling and a different volume. And you'd be talking to them about 2 to 3 hours a week of structured exercise, low and medium intensity for half of it, and combining it with strength training, which also has the same cardiovascular preventative benefits. So a lot of the evaluation is where they sit between those 2 poles.